So as with the last conference, actually, it was very successful having an expert panel, an ability to kind of take the whole conference in summary and ask some questions. And we pulled together this expert panel of both a cross-section of the medical community as well as our HCU family. We have an HCU mom and an HCU patient. So I'd like to introduce the group, and then what we'll do is we'll do questions as normal. I'll get a few questions going, but I don't think I have to persuade this group too much with questions. You all know Dr. Chapman. Without introduction, obviously she's the HCU and metabolic extraordinaire, and she's been great in terms of giving us our guidances and summaries yesterday, and I'm sure we can ask her some more questions today. Next is Katie Sapp. We learned from Katie about the world of geneticists and genotyping, and I'd like a question on that algorithm and formula that you talked about, but I'll spare you on that. I think some of the the breakout group, met Abby Hall. Abby's a dietitian, actually works with Katie at the metabolic dietitian, see, this is what I did yesterday. I didn't bring my glasses, so. The IU Health Physicians at Riley Hospital here in Indianapolis, so thanks Abby for joining us. Next is Rachel Skeens. I think some of you have met her along the conference way. She is a mom of Landon. Landon's 12 and was diagnosed at the age of 4. Her journey, her and Justin's journey, is just an amazing story of how a mom and dad can advocate for their child to really get them to a point of diagnosis, and then more importantly get them into a state of control and managing their HCU. And the handsome gentleman to my left is Ben Lewis. Ben is 28. He was an HCU patient that was picked up by newborn screening in the state of Massachusetts. Dr. Levy will tell the story that he was about this close from actually being picked up. And so fortunately he's been on diet since about 6 weeks old. He has an undergraduate degree in business and finance from Rensselaer Polytech, and I think magna cum laude, might I add. And he just polished off his MBA at Babson College. So Ben has navigated his young life here through various transitions. So I hope we can learn more about that and his successes as he's made those transitions. So let's start with a couple questions. I'll start. I'm sorry, I did some paper again. Kim, I was going to ask you start with a broad question, and I think I still will, but I do want to ask later a question that's been rumbling through the crowd about B12, but I'll hold off on that. You're sitting in front of one of your HCU patients. What is the most important thing that you can convey to that patient relative to the management and treatment of their HCU? What's the thing that you try to push for most in terms of their diet and their management of their HCU?
Well, so the thing I really push is that I want their total homocysteine to be less than 100 because I really worry about thrombosis. In most cases, that can't be done without diet. And so we can talk about medications, but I want them to be as open and clear with me and my dietitians about the dietary challenges they have. Because if we don't know they have a challenge in terms of drinking their formula, we can't give them additional options. Or if they are desperate for another recipes. The other thing I really want them to do is call us. So it is not a single thing that's ever happened where we get called on like a Friday afternoon and one of the patients is on the phone and says, "Hi, I'm going on a date tonight. What can I eat?" Because I don't want the first conversation to be homocystinuria. And so just being open and clear, but that usually I can't get away with you not doing something for your diet. We'll work with your abilities, we'll work with your circumstances, but that's about that's kind of a limitation, especially with CBS. If it's a cobalamine C, if it's an MTHFR, it's a slightly different conversation.
Thanks. So Katie, Katie, I have a question for you. It's actually perhaps something you can answer with Dr. Chapman. Yesterday we talked about genetic testing, siblings, family members, etc. And then I think we get that. There was a lot to digest. But within the conversation, I'm wondering, is there something, advice that perhaps the clinic gives along the way for a sibling that may be testing positive as a carrier? Is there anything that sibling should do differently in their lifestyle, in their dietary needs, and so forth? Is there something that should be considered outside of the HCU patient itself?
So I think for siblings of HCU patients who test positive for carrier status, you don't need to change anything about your health or your medical management. I think that really the only time we tell families that information comes into play is when that individual is planning a family of their own. So carrier status is really only helpful for reproductive risk purposes when we're talking about siblings of patients with HCU. It's more about understanding the risk for them to have a child with that particular condition. And I think it's important for them to understand that it's not just about their carrier status, it's about their partners as well. So kind of like you were saying, you don't want the first conversation to be HCU. I think that's very true of siblings who are carriers as well. You don't want that to be the first screening question you ask a new date.
And they won't know anyway.
They won't know anyways. That's a down the road kind of conversation. But something that, having that knowledge or at least knowing where to go for that information as far as recurrence risks and those numbers, and then deciding how do you feel about those numbers. For some people, the number I think we flashed up yesterday for siblings is a 1 in 1,500 chance to have a child with HCU as the sibling of an affected person. And some people think that number seems really, really high. And other people think that number is less than 1%. And there's no right or wrong way to perceive that information. It's all very personal. So just being able to take that information in, decide how you feel about it, and then understand what your options are related to that.
Awesome. Thanks.
And I was going to add, in 2019, being a carrier at this point, we don't think increases your risk for things as you get older. And I say at this point because whether that is going to change in the future, now that we've identified a large number of individuals who are affected and a large number of individuals who are carriers, but currently there doesn't appear to be an increased risk for carrier status.
Great, thanks. And actually, a quick story, Karen and I, years ago when Ben was first diagnosed, we were actually invited to be part of the Framingham Heart Study. Because we were carriers, and they did a whole makeup on us and really analyzed what our metabolic makeup was as carriers, not necessarily as a HCU patient. I don't know where that data has evolved to, but as Kim points out, we may learn some things that perhaps our pharmaceutical friends may be looking at the broader population of HCU. Since the carrier the prevalence of carriers is much higher. Is there something within that population that's maybe different than perhaps a non-carrier population? But thank you.
And we're all carriers for 8 to 15 disorders at the very least. So
Yeah, good point. Where do you stop? So Abby, I wanted to ask a question. You're a dietitian. You're meeting these HCU patients. The world of dietary management has changed. When Ben was first diagnosed, it was the Virginia Schuett only and very little options. What tools do you use when you're sitting down with an HCU patient and talking to them about their dietary needs?
Yes, so things definitely have evolved with the dietary, how we talk about things, what we kind of do to manage. So I've been a dietitian now at the clinic in metabolics for about 7 years. So I've even seen kind of some transitions from, milligrams of methionine or whatever amino acid in conditions to kind of grams of protein, that sort of thing. So there's definitely been a learning curve. It's different for every family. With your question, so it's gonna first, what stage are we at? Or is this a newborn screen? Is this a new baby? Is this a 10-year-old who's been, doing a different lifestyle and now having to change all of that? I think it's all, as I think everyone's kind of talked about, it's really looking at the situation, where the family is, what's going on, kind of where they're coming from, and where we need to go. So everything's so personalized because even in your own family, you might see differences in the needs of one child versus another child. So I think just connecting with the family, I think that's the first thing that one needs to do to kind of establish that trust and that relationship, and just that constant communication, always being available for a phone call. We want to know if they're not drinking. We want to know if they're refusing every food. So those things are only the things that are going to help us. So I think us knowing all the details, kind of taking that situation and saying what's going to work. So I think just personalized everything, because I eat differently than you, and you eat differently than, so it's all, diet is so specific, and I think it's just listening and talking with the family. So I wish I had a magic potion.
So next is Rachel. I'm going to have her sing a little song. No, as I've said at the beginning of this, and I think many of you have met Rachel, it's between her and Justin, it's quite a journey between when Landon first was showing symptoms of something. It was many, many years of really searching for an answer. And as a parent of an HCU child, it's really motivating to hear your story, in that you push so hard as an advocate for your child. So I'd like you to just talk us through that, and what kind of advice do you have for someone that's either managing through a diagnosis, or even managing through your child's overall metabolic health, and the things that they are challenged with. Maybe you can share some of that with us.
So Landon wasn't diagnosed until he was 4, and we had a normal pregnancy, a normal birth, but he had issues as soon as we brought him home, things like reflux, and he always cried, and he just wasn't a very happy baby. So we thought maybe just colic, and we continued raising Landon, and then around 9 months, Landon was not doing anything that other babies were doing. So I took him to his pediatrician, and she said, well, he's not failure to thrive, and he looks good on the growth chart, but if you're concerned about this, then we can put you in a program. West Virginia has a program called Birth to 3, and they offer therapies. So from the time Landon was 9 months old until just last year, he's been in speech therapy, occupational therapy, and physical therapy. But now he's been released from all that. He's doing well. So through that program, he still was not making progress. And the progress that he did make, he would lose. So I think we went through close to 7 pediatricians, and not because they were ever, mean to us or didn't treat us well, but because when I would go in and say, Landon's head looks larger than it should, do you think we need an MRI? Or Landon, every time he eats, he has terrible reflux and he cries like he's in pain. Or they would say, we can do this blood test, but you're really wasting your time and your money. He looks good. He'll be fine. He's a boy. So as we went down the road with that, we got autism as a diagnosis. We were told he was mentally challenged. We were told so many different things, but one thing that was consistent with everyone was we were wasting our time, to stop. We're wasting Landon's time. We were running out of money, and resources. So no one supported me. One family member supported me. So even the family at that time was like, you're a little crazy. You need to stop. But I was home with Landon all day. And so it was literally like a light switch flipping, is how I would describe it. He would talk, he would be walking, and then the next second, he had lost the word that he just knew. So finally, our 7th pediatrician saw Landon when Landon could hardly walk and hardly talk at the age of 4. And he said, your baby's going to die. You need to get him out of this state. So we went to Cincinnati Children's, and of course I had this huge pile of everything we'd ever had him tested for. I'd already mailed it to pediatrics. And we walk in, and the head of pediatrics is there, and the first thing she said was, "Why are you here? You are wasting your time. You've already had all this testing done. He's clearly mentally challenged, and you just have to accept this." And I've always been nice and calm at all the appointments, and I just said, we drove 5.5 hours. We have no money. My son cannot move his left side at all at the time. Will you please just look at him? And she said, yeah, I'll look at him. So she did, and she agreed that his left side was a lot weaker. So they did an MRI. And then they told us, the neurologist brought us in, and he held my hand, and he said, Mom, all I can do at this point is hold your hand, because your son has metachromatic leukodystrophy, which is white matter all over the brain. They said it looked like he'd almost been in a motorcycle accident without a helmet. And he's going to pass in about 2 weeks. So we went home, and we kind of prepped ourselves for not having Landon, however you do that. And then we got a phone call. I'll never forget it. Landon liked to play soccer when he could. So that evening we were at the soccer field, and I don't even think he was playing a game, but he was standing out there with the other kids, and they called and said, Landon has homocystinuria, and it's treatable. And we said, yay, which is probably not a reaction they expected. But we knew, and it was treatable. And so about 6 months after he began diet and medication, he got back to, he gained some strength, and he was relearning and able to talk and things like that again. And now if you look at him, he's perfectly normal, a little sarcastic. I don't know where he gets that from, but he's doing great. So my advice is to, if you feel something about your child in your gut, it's more than likely accurate, and never stop questioning your doctor. Don't be intimidated by the nose or by their level of intelligence, because we're parents, we're with our kids, we know them better than anybody else. So I would just say to really, really push forward with whatever you think is best for your child, and then of course go over it with the doctor. But so.
Thank you. That's amazing story. I think advocacy plays across everything, not just with pushing for a doctor or another doctor, but a first grade teacher and so forth. So thanks. So this next guy, I'd like Ben to talk to us a little bit about, you've transitioned across your young life through a number of things as we discussed. You navigated the perils of high school, and you moved on to college, and now you're living an independent life with a busy career. How did, pick a point in your life and one of these major transitions, how you managed to balance all of that and manage your HCU and help the community understand the successes, how you successfully, made each of those steps in your life, Ben?
Yeah, sure. And it's probably worth starting out with the fact that you keep mentioning my young life. This is probably a 50-50 split in the audience right now as to whether I'm 22 or 28 based on the conversation last night.
You're younger than me.
Yeah, but so yeah, I am 28 at this point. So I've been through lots of different schools, and I'm working right now. And yeah, I guess to pick a point, maybe I'll go back to college because it can be some of the biggest transition that everybody makes in life. And I think I've always been clear that, especially after coming to the conference last year and seeing the community and how folks manage their diet, that there are people in this community that I would much rather put up on a pedestal for diet and disease management. I've done well with it, but I was very impressed last year hearing from folks as to what they get their levels to and the things they go through from a diet and a treatment standpoint to make that happen. So, if I look at the college period, like my adherence to the treatment and the diet was, it varied, and it was rough at times. I mean, if you look at the beginning of my college experience, I went to a school about 3 hours from home, so kind of just far enough away not to have my family support network available to me on a everyday basis, and really had to kind of figure out how to, the first time ever, figure out how to manage the treatment and the diet without really any support. So freshman year was tough because we thought we had put in place, as my parents and I, the right support system at the school to enable me to continue doing that with something, some sort of structure that would give me what I needed to, be a healthy HCU patient. But the long and short of it is that didn't really work out. They sort of put me in a program that was for anybody that had a special dietary restriction, and the majority of the folks in that program just don't have the same considerations that a lot of us with HCU have. So, between having the logistics to get my formula, or accessing the food that I got, the low protein food I got, and getting it prepared, it just all didn't fit well with my schedule. None of my friends, new friends at college, had to go through anything like that. So, really, I think my diet management and my medication management freshman year was probably not the best. And I wasn't even, on top of that, it's really the first time in life that my blood draws and measurements were a lot less frequent. So not only is the management not maybe that great, but don't even really know what the results are, although you could probably guess that they weren't that great. But the thing is that, and there is somewhat of a connecting point to the advocacy theme that we might develop here, is that you can't just sort of accept that type of lot in life, or in this part of life. And, we sort of went back to the drawing board. And that's probably a nice way to say that primarily Mom probably yelled at some people. But we went back to the drawing board for sophomore year. And, we said to the school, I had kind of decided at that point that I'm going to be on campus all 4 years. It seemed to make the most sense. I'm going to get a meal plan all 4 years. That it just didn't work. So we got to figure out something else. And, for the next 3 years, the school really responded, which is good. And I think it was certainly in no small part because of what we said to them and did after freshman year. But I was one of the chefs in the dining hall that was closest to me, was sort of assigned to me as my somewhat personal chef. And for the next 3 years, I had to be flexible. People are pretty picky about what they eat, but I kind of had, I had this guy who was going to work with me. He did this as a job, right? Cooking, full time. And, I could have gone to him and said, well, I don't like, mushrooms or whatever. And, therefore take this really strict diet that we need you to follow and then cut it down to basically nothing. And I just don't think that, that wouldn't have worked. So, I think what really that boils down to for those 3 years and led to success in management of the diet and the treatment was, we got the right structure in place. We kind of forced the school to really do something that was going to be meaningful. And then, I kind of had to give some freedom to that person and those people who helped me with, the food and the formula, so that it all worked well, and I think that's the thing is it really, I guess, as I said, the theme, theme one is like the advocacy piece, but then two is, people want to help you. You just sort of have to make it work for them too. And, You know, when you're on a strict diet, you know, it just can be hard to, you know, start sort of cornering yourself by continuing to, you know, eat away at that, so to speak. So, yeah, so I think, you know, that's the thing with that transition in particular is it's really just a, you know, don't be afraid to, you know, sort of stand up for yourself or have your, you know, support network stand up for you, because you just gotta kind of make yourself known. Because, you know, at a college, in that example, there at my school, there's 4,000 kids there, and they have to feed every single one. So, you know, gotta kind of make yourself stand out from the crowd.
That's awesome. Thanks, Ben. Questions from the group? We covered everything.
Can I ask Ben, did you get to be a really good friend with your chef?
So you want to repeat the question?
Dr. Chapman is asking if I was friends with my chef. I did actually, yeah. I became pretty good friends with him. It kind of ended up being two. So the first guy I was working with actually kind of got promoted and became the manager of the operation, and I still talk to him, and occasionally he would come out and give me some of his own special like recipes that he had developed. But yeah, then I moved on to the second guy, and yeah, I mean really.
We did buy them gifts.
Yeah, we did buy them gifts. Yeah, they didn't do it entirely for free.
We bought them some presents.
But yeah, I mean, it was funny. So got to know them. I think another interesting point that's somewhat related is like, you know, it's a little bit unique situation. But you know, I had friends who would come eat with me, and you know, sometimes there was, you know, I mean, dining hall food at RPI where I went to school is like actually pretty good, but you know, when you have a private chef who's going to cook whatever you want, it tends to be a bit better. And he loved it actually too, because he got to be creative in a dining hall environment, which doesn't happen a lot. So yeah, basically like he was happy, we had a good relationship, and you know, I had some friends that sometimes benefited from having an inside person in the kitchen who could get them, you know, strawberries or whatever they wanted. Yeah, so I mean, overall, kind of a really good dynamic that developed out of that.
Yeah, we did send him gifts. Letters to this boss and everything. I mean, you got to take care of the people that are taking care of you, right? And this was a special person, and as parents, it made us feel a whole lot better that Ben was getting the attention he needed. Danae.
I actually have another question for him. Sorry, you're going to be picked on a lot. I have. The transition from college to the next, usually the next step is moving out on your own and into career. I'm sure your mom did a lot of cooking when you lived at home. You had the chef, then at college. Now it's you on your own. Did you find it a lot harder to make that transition to independently now that you were accountable for your own food? And how did you handle that?
So yeah, the question, I think everyone caught it for the cameraman's benefit, is that as Ben made these transitions, but then as he transitioned to be on his own, you know, we lost his personal chef, and he's not in close proximity to his infrastructure. How did you make that adjustment? I feel like that was planted to some degree, but it wasn't. Yeah. So as you can imagine, I'm now not a chef. I don't even think I can say the best chef. I'm just not a chef, because I had a chef, or two chefs, I guess, technically, depending on how long you look back. And yeah, so I think that was a challenge. The sort of pro and con about life after college is that usually you end up with some sort of pretty regular schedule, you know, in a lot of cases. And so, you know, so I have a fairly regular schedule with some, you know, variation that happens. But, you know, as a result, and I was talking about this last night with a few people, is like, I sort of just treat, you know, you sort of treat each meal, you know, you think of them together, and then you sort of treat each one differently depending on what you think is going to happen with your schedule. So I'll sort of make that real. You know, for me, I don't really eat breakfast. I mean, I have you know, I have formula in the morning, which is essentially a protein shake. So, you know, probably just as good as some sort of breakfast for me, at least. You know, I go to work, you know, 5 days out of the week. I'm going to have lunch. You know, I was mentioning last night that, you know, I don't always have control over that.
in a lot of ways. So, maybe 4 out of the 5 days in the week, I can, I'll purchase lunch in our cafeteria, so I have some control. But then the 5th day, we might have a catered lunch because of a meeting, or I might go out to lunch with a partner of ours or something like that. And that means control is decreased. So as a result, maybe I have limited choices, but I'll still try to make the best choice based on my diet. But then what I do on that 5th day where lunch isn't controllable is you have to go home and have dinner, if you can. Again, sometimes it changes, but you have to tailor or change dinner depending on how lunch went. So that's kind of how I deal with it now that I'm out of college, is kind of thinking through each of the meals in the day and trying to adjust one or the other depending on how I think the schedule is kind of developing. Some days that just doesn't happen. You might have a lunch with a partner, and then I'm in a group that deals with partnerships, and you go get dinner with a different partner at the end of it, and so sometimes it kind of blows up, and you have a higher day. You just gotta. For me, what I try to do, especially on those days, is make sure I get all of my formula and all of my betaine, and maybe that ends up being a little bit of a higher day from a sort of homocysteine level perspective, but you just try to minimize that and kind of manage around it essentially. So that's kind of how it's worked out after school. But I still can't cook really. So
if I could add, Ben, you're in a business situation. You go out to dinner, it's lunch, whatever. You're still able to navigate the menu, right? To at least lean in your direction, right? Are you finding that in the business world, with the elbowing of clients and people and all the things that go on there? Are you able to advocate for yourself and say, I'm gonna hang on this side of the menu, or I'm gonna get a bunch of sides of veggies or something? Is that how you roll in those situations, or?
Yeah. So I find that most of the time there's some option that fits fairly well with the diet. These days there's so many diets out there. A lot of people, at least in the Boston area, which probably is one of the healthier areas in the country, but they tend to be vegetarian or vegan. So we often, even if we're catering lunch, include a vegetarian or a vegan option because we know we're going to need that for somebody in the meeting. When you go out to eat, you try to have control, and people are, have been accepting of that. I actually had lunch with some folks from a company I know on, I think it was on Wednesday, and the guy was coming into town. He said, where should we go for lunch? I'll be in this area of the city, you're in that area. And I said, well, you can choose. Just let me know what you think beforehand. Because, I have some dietary considerations, and I just want to make sure it works for me. And so he found a restaurant, let me know about it. I looked at the menu, and, it in that case, it worked out well. In other cases, sometimes people have chosen whatever, like Shake Shack or something like that, and then you might have to do a little bit of negotiation, I guess, to say, well, I don't know if next door there's a Chipotle or something. You think that you might be able to find something at, like, maybe would you be okay with that over the Shake Shack? So
Excellent. Any other questions? No other questions.
Can I ask our dietitian, how do you find with younger children, managing, especially once they go to school? Can you talk about, managing that with school lunches, et cetera?
Yeah. So the question's, making the transition to school lunches, and how do you work with the school environment to get the meals or the diet you need?
Yes, so there's definitely a lot of different approaches. Again, it's going to we talked about this in our breakout with the 5 to 12-year-olds. So it's going to start with what the family's expectation is. Does the family want to pack the lunch? Do they want to, see what the school has options. I think personally, having the conversation with the school to see what they're able to provide or how they're able to help out. Are they able to get low protein foods? Every school is going to be different, no matter if it's public, private, whatever, college, middle school, elementary school, daycare. Everyone's going to have their preferences. I think by law they are all supposed to work with you and give the student what they need, but every school is going to take that the way they want to. So I think first having that conversation, again, as a family, knowing what you want. So do you want to have that control? Do you want to make sure that they eat what you sent and not have any, options from the cafeteria? I think just working with each individual family is going to be kind of where you're at. I was talking in our group, so we do send as our clinic, no matter if it's a daycare, a preschool, a high school, no matter what school it is or what age, we send a diet letter at the beginning of every year, sometimes in the middle of the transition, so from first semester to second semester. Just a brief overview. Every letter has the same structure, but it's all a little bit different verbiage. But it says what the disorder is, what the main offending, it's a low protein diet, avoid these foods, and then it goes into details based on what the family wants and what the school is needing. So I think that's very important. Again, having those conversations, but unfortunately, sometimes that signature of the doctor makes them take it a little bit more seriously. And then sometimes there are some, flubs of the school. But I think, again, taking it individualized, but I think always having that conversation, I think the 504 plan would be what you would need to establish kind of those rules, but also maybe an IEP kind of flowing into it. And I think the biggest time that you really have to open those conversations is a big transition to a new school. So elementary school to middle school, if it's going to be a different school. High school is a whole other ballgame when it comes to food. Your kid who's been eating your packed lunch for the past, 8 years might be fine with that. But high school, their friends might be getting this. So I think you have to always be open to what the student wants, be able to work within your comfort level, but also be able to reach out to the school and have kind of those go-to contact people. So
A lot of times the schools will have the doctors fill out forms, so the medication forms, every single year.
yes.
And sometimes these forms include special diet forms. Every single year. And she's laughing at me because
August. We do a lot of things.
July, August. The worst thing in the world is when it shows up on the first day of school and they want it now.
Plan ahead.
Plan ahead.
Plan ahead.
Please plan ahead. Or they say, well, you can get the form on the internet. I find that very complicated.
Yes, I agree. So I've had parents call me say, they can't eat tomorrow. Can you get this to them? So I don't think you guys would, any of you would do that. But yeah, just pre-plan because it does sometimes take a little bit of time for us to get everything together. So, and I've actually had conversations and gone through menus with dietitians who work at the schools. And I know Cambrook has their school food program. So I'll be honest, I've been working for 7 years, and I have never had success with that until this year.
We have several
yeah,
folks on this
good,
board, yeah.
good. So, but yeah, I had a dietitian, and it was actually, I think it was an isovaleric acidemia and a glycogen storage disease patient all at the same school. And the dietitian was wonderful to work out. She sent me all the menus. We went through both of them, obviously very different diets. But it's definitely, finding those people that you can connect with and that are going to help be you while you're there at school.
Thanks. Any other questions? So I promised one quick question for Dr. Chapman. I've heard a little bit during this conference some folks talking about B12 injections, and I was curious what your thoughts are on that.
Can you, in general, talk about where B12 falls into play with?
So
In the beginning and then?
in the beginning. So B12 is necessary for methionine synthase to work. And methionine synthase converts homocysteine to methionine. there is a number of individuals with homocystinuria where they cannot process B12, and these are the cobalamin disorders. And in those cases, you have to take B12 injections. It's a major component of the therapy. If you're talking about Cbs deficiency, B12 is required for methionine synthase to work, but if you're not B12 replete, so you're not full of enough B12 or folate, betaine doesn't work. Okay, so there's a lot of discussion about how do we get B12 into individuals with Cbs deficiency. This can be by injection or this can be orally. Because a lot of folks have started with the background of cobalamines, many folks with Cbs deficiency will get B12 by injection because we're trying to replete it. It's easy. We're not trying to add another pill. Easy as in it's an injection. And the evidence demonstrates you have to be replete. And you're not going to get B12 in your diet. It might be in some of the formulas, but in generally, it's not a great source. So most people have to be on B12 as a supplement. So different clinics have different approaches to make sure someone's B12 replete. And so some clinics will do injections in the CBSs, and some clinics will do oral replacement. And I think there's a patient and a clinic specific kind of things. There are, in fact, some people with CBS that the injections will work better because they're bigger doses and they don't absorb the B12 as well out of their gut. And there's some individuals where the oral will really work well. This is not applicable for any of the cobalamine disorders where you have to have it injections because you need that much higher pharmaceutical therapeutic dose to get benefit. Did that answer the question?
Yeah, I think so. So do you, and you may have to repeat my question because I'm not walking over there. Do you recommend HCU patients have a discussion with their physician about B12? Is there a dialogue there, or do you think, as you say, they're just watching the levels and...
So I think it's totally fine to ask your physician whether they think you're B12 replete and whether or not we have to measure it. This is what gets kind of challenging with that question, because the first issue is, you know how you check B12 in everybody else, or how internal medicine looks for B12 deficiency? They look at MMA and homocysteine levels. So I've actually checked MMA levels in a CBS patient and got a call and said, they have CBS, you know you're doing that, right? Okay. So, and then you can also look at B12 levels. B12 levels are not the most effective way to look, because you can have somebody that is deficient enough that their enzymes that require B12 aren't working well enough, and your level can be in the normal range. Low normal, but in the normal range. And you can have somebody that is totally, their enzymes work just fine, they clearly have enough B12, and their level is considered low. So that's where it gets really complicated. Like, how do I figure out if somebody's B12 deficient? And then it gets doubly complicated. How do I figure out somebody's B12 deficient when they have Cbs deficiency? And one of the best measures of B12 deficiency is abnormal because of their underlying metabolic disease.
Another question for you.
Yeah.
Is MMA methylmalonate?
So MMA, what is MMA? Methylmalonic acid. So methylmalonate is another name for it. Yeah. So the answer is yeah. Sorry about that. It's some of the slang that goes along with it.
All right, thank you. All right, we're going to wrap up, and I figured we'd just throw a question to a few panelists or two as a conclusion, and I'll pick on Rachel. So what gives you hope about the future? Where, based on your journey and what you've learned in this conference and the medical community and that, wonderful presentation about the future. What gives you hope about, Landon and how things are going to be for him with all this this community and this science that's going on?
Well, I feel like for sure in Landon's lifetime that there will be some sort of a therapy out there that will allow him to eat a normal diet and not take as much medication. I really have a lot of hope in that. And I also am so glad that, not to say HCU is normal, but it is becoming more normalized and easier to talk about with your doctors. A lot more medical professionals know about it now than they did 6 years ago. So.
Well said. So I think that's it for the panel. Thank you, everyone. And I think we're going to do a lunch break. Yeah?
Danae, I just have one more. You go up to the.
Oh,
We'll let the panel dismiss.
you're dismissed.